Ciao mondo, hello world, hola mundo, hello monde. We're here today in Barcelona at the European Society of Cardiology Congress taking a cappuccino with Professor Peter McCullough from the Baylor University Medical Center in Dallas, Texas. And in particular, we had a fantastic symposium on a topic that we may probably define one of the hottest topics in cardio-nephrology. Should renin-angiotensin system blockade be stopped or discontinued or mitigated or titrated when patients start to have a declining renal function? So Peter, what is the result of this debate that we had today?
Well, we had a terrific debate, Claudio, and we had two teams. Each had a cardiologist, each had a nephrologist. And, you know, these drugs, ACE inhibitors, ARBs, direct renin inhibitors, and mineralocorticoid receptor antagonists do have a benefit in patients, primarily those with progressive heart failure that we see in the office, patients with chronic kidney disease who have proteinuria, again, we see in the office. But what I learned from this debate is that when patients become decompensated, particularly when they are hospitalized or when there's excessive blockade of the renin-angiotensin system, we can have adverse events, including hyperkalemia, including elevations in BUN and creatinine, clinical scenarios where we start to withdraw various agents. We believe pathophysiologically, potentially an impaired tubulo-glomerular feedback, impaired perfusion to the kidneys, and in fact, some of the presenters intimated that in fact these drugs may cause harm in certain scenarios of combined heart and kidney failure.
Okay, so assuming that hyperkalemia and maybe hypotension represent the major limitations of this drug in this patient, if you would be able to overcome these problems with either additional strategies or drugs, would you slightly change your opinion?
Yeah, it was the view, I think, of almost all the panelists that if we had a therapeutic approach, a preventive approach, that could reduce the risk of hyperkalemia, which is difficult to anticipate its individual risk in a patient. In particular, the EKG doesn't help us too much in terms of predicting cardiotoxicity. If we had an agent or a set of agents that allow us to reduce the elevation that we see in potassium and have greater potassium elimination from the body, it would almost certainly enable more widespread use of these drugs in a safer pattern for patients to improve outcomes.
So these drugs, to conclude, and especially dual blockade, may be important in some patients. Guidelines describe different situations, but we have to monitor every single patient for potassium, for blood pressure, for possible adverse event. At this point, I think that we should just recommend our friends here today to follow the literature, to look more into the details of the evidence and considering stopping in some patients when GFR is declining. On the other hand, continuing if adverse events can be mitigated. And with this, I thank you very much for joining today at Cappuccino, and have a nice day. Excellent.